Hello friends, now let us continue our topic on urethral injuries. I'm sorry, I should leave in the middle. So, in our last class, we have dealt with the etiology and classification and investigations and clinical features of rupture of membranous urethra. So, in this class, we will learn about the treatment. Even in the treatment, I have dealt with the floating, what happens if there is a complete urethral rupture. I'll just refresh it so that it will become easier to us. So in complete urethral rupture, there is rupture of here, there is transection here. So completely it was ruptured, so there is only floating prostate which is seen, right? Which is called as Vermeuton sign. Vermeuton sign. So now what do you do? Here there is a transection, right? So first, let me, I have already drawn it and I have even explained it in my previous class, but here I would like to explain it clearly. So first the bladder, we will open the bladder and then we will pass a metal bogie through the bladder. So this is the metal bogie. So once you pass a metal bogie through the bladder, it reaches till the urethra. And then you will pass another metal bogie from below. Okay, so this is the second metal bogie, and such a way that these both will meet with each other. These two metal bogies which were there, they should meet with each other, and then this lower metal bogie should reach the bladder. So it has reached the bladder, right? So now through this lower metal bogie, you will attach a rubber catheter from above, because we have opened the bladder. So through that we will attach a rubber catheter. Once we attach the rubber catheter, we will pull this down like this. If we pull this down, this rubber catheter aligns it in this way, right? So with this help of rubber catheter, you will now pass a Foley's through it, okay? And then this is already present, right? I'm forgetting the colors, okay? Here this superior metal bogie is also present. Now what do you do is, you will replace the superior metal bogie with Malakoff's catheter so that there is drainage of the bladder like this, and then you will close the bladder. So this technique is called as railroad technique. It is done for floating prostate. Right guys, so this is the open procedure which is done for floating prostate. Now what do you do if there is incomplete rupture? This is the second type. Oh, I'm sorry. So, when there is incomplete rupture, what do you do? If there is incomplete rupture, you can do it by two approaches. Number one, Mitchell's approach. First, Mitchell's approach. Second, by Blandy's approach. So what do you do here? So if you see, this is the bladder, okay? This is this prostatic urethra, and then membranous, and then bulbar, and then penile. Okay. Here we don't pass the catheter from below, but because there is a partial transection, so here there is just a part of it was transected. This was already present, so this part is transected. So you can't pass a catheter from below, because this may further damage the sphincter. So what you do is, you will have to pass the Melkert's catheter. You'll have to open the bladder and then do a suprapubic cystotomy using Malakoff's catheter. Okay. So now what do you do is, you do a suprapubic cystotomy and then put Malakat's catheter. Okay, and then after 3 to 6 weeks do a urogram. Sorry, urethrogram. Then after doing urethrogram, then using endoscope or open, dilate the injured part and then pass Foley's catheter from below. Because through this time, during this time there may be formation of stricture. So you'll have to dilate the stricture and resulting in, and then you'll have to pass the Foley's catheter. So that is for Mitchell's approach for incomplete rupture. So what is Blandy's approach? What do you do? I'll do it in my next page. Okay. In Blandy's approach, what we do is, so this is the bladder. And then this is the prostatic urethra, membranous urethra. Okay. So now what we have to do in Blandy's second approach is, you'll have to pass a soft catheter urethrally, and then you have to reach till the bladder. So let me draw it. So you'll pass a soft catheter urethrally gently into the bladder. Okay, that is the first thing which you do. Then you'll keep it in situ for 1 day. This is kept for 1 day. And after the second day, what do you do? So this is bladder again. Okay, this was already inside. If this success, then keep it like this. If there is failure, if it fails, okay, then after keeping it for 1 day, then on second day, you will have to do a if it fails, then if fails, do a suprapubic cystotomy as we have done before, right? If it passes, if it succeeds, then you have kept it for 1 day. On the second day, this is on second day, what do you do? On the second day, you'll have to go to the operation theatre. Then what do you do? You'll have to go to the operation theatre, and then this is the bladder, this is the urethra, prostatic part, membranous, and then bulbar, and then downwards. Okay, in the OT, okay, open the bladder, number 1. Operation theatre, in the operation theatre, open the bladder, and then pass a cystoscope, flexible cystoscope. So there is already this what do we say, soft catheter is already there here. So through this soft catheter, you will pass a cystoscope. So I didn't need, yeah. Then through this soft catheter, pass a cystoscope like this. This is not working. I need good. Just a minute, guys. Yeah. Pass a cystoscope. This is the cystoscope. The both ends of cystoscope. And then using this cystoscope, catheter is passed. So now cystoscope is passed, and then after passing cystoscope, so this is cystoscope. Okay. And then you will remove this soft catheter, and then after removing soft catheter through this cystoscope, after removing this soft catheter, remove the soft catheter, there will be only the cystoscope which is left here. This is the cystoscope. And now through this cystoscope, pass the Foley's catheter. Yeah, this is here. Right? Pass the Foley's catheter. Now, this Foley's catheter will be in place. So, this is what you do. And then, close the bladder. With suprapubic cystotomy also. So, that there is the double way of drainage. Right? So, this is what we do. But if the patient presents late, there may be chance of formation of stricture. So, when stricture forms, we can never do anything. The only thing is treat it in the management of stricture wise, right? That which we will deal in our next class. So, this is about the membranous urethra, rupture of membranous urethra. Now, coming to the second topic, which we will deal today here, which is rupture of bulbar urethra. What do we do if there is a rupture of bulbar urethra? Okay, so that is what we'll learn now. So now, injury to bulbar urethra. Okay, so now etiological factors. The most common etiological factor is some history of blow to perineum. Why is there a history of blow to perineum? It may be due to fall on projecting object, or some other accident, basically cycling accidents or gymnastics accidents, anything, any type of accidents. All these may lead to blow to the perineum. So this blow to perineum may cause rupture of bulbar urethra. So what are the clinical features? So here, these are similar to the previous one. So if you see, this is the bladder. Now, this is the prostatic urethra, membranous urethra. Right. So this is what is there. Membranous urethra, bulbar urethra and penile urethra. So there is transection here. So there will be number 1, retention of urine. The urine does not pass. Because if you see, there is external sphincter here, right? So because there is external sphincter here, there is the external sphincter will be taut. So there is retention of urine. So if you see in the membranous urethral injuries, there is extravasation of urine. Here there is retention of urine. And then there is hematoma formation. And because of this, there is bleeding from external urethra, external meatus. Right? So these are the major clinical features which are seen. And then, what do you do initially if this patient presents to you? So first, when the patient presents to you, then what you do is management. Before going through any investigation, first we have to stop the retention of urine. For this, we will place place a catheter first into the bladder so that there is drainage of urine. This is kept by percutaneous suprapubic puncture. Just percutaneously we puncture the bladder. Suprapubic puncture of bladder. Right? So if this is the bladder and this is the pubic bone, or here if you see, so what we do is we just percutaneously we will puncture it and then we will pass a catheter. We don't open anything, open the bladder. Okay, this is what first we do, and we will drain the urine. So this will drain the urine and thus there is decreased urinary retention. Okay, next, that is the first thing which we have to do, and then we'll have to investigate later. After doing this, the main problem was solved. One of the major things was solved, so we'll have to do investigation. The investigation includes X-ray pelvis, and then the second one, ultrasound abdomen. So these are the two investigations which you do to see whether there is rupture in the urethra. And then treatment. How do you treat it? So here the main worry here is, if we catheterize the urethra, this might result in conversion of partial tear into complete tear. Right? So here, first the patient should be told that never try to pass urine. If there is this issue, never try to pass urine, because if he passes urine, what happens? Then there is extravasation of urine occurs. So, in operation theatre, one attempt to pass the catheter is made. If passed, then keep it in place. If failed, if it does not pass, then under general anesthesia, in lithotomy position, you should do suprapubic cystotomy. And then you'll have to expose the bulbar urethra. This is first which you do, and then what do we do? And then I'll draw a diagram. That would be better instead of writing all these. Okay. Okay, and then through perineal incision, you'll give a perineal incision here, and then you will approach it. Okay, through the perineal incision, perineal midline incision, you will approach it and you will suture the tear. Here there is a tear, so you will suture it. After suturing it, you will keep an indwelling catheter. So catheter is placed and then the drain is placed in the perineum. So we keep a drain so that it bleeds in the perineum. So, the urine comes out through the perineum. So drain is placed into perineum. So I think you have got it. So what we do is this is the bladder wall. So we approach it perineally. So we make a mid line perineal incision. And then we approach bulbar urethra. And once we approach the bulbar urethra, what do? We will suture it. And then put Foley's and drain Foley's catheter. And drain is placed in the perineum. So this is what generally happens. Now, if we can't suture, what happens? If we can't suture, because it is urethra, if you see, it's very, very small. If we cannot suture, in such cases you should do perineal urethrostomy. So now, this is what generally happens. So now, what are the complications overall? So when if you see in complete urethral stricture, I said we'll keep a catheter. Then what happens if we keep a catheter? What happens to the injury? We'll keep the catheter for some 1 or 2 months or 3 months, and then we'll leave it. And then once you remove the catheter, the injury is healed, because that is the time required for healing of urethra. So we are just allowing it, giving it time to heal. But we can't remove it just like that. We can't ask the patient to heal on its own without keeping a catheter. If we don't keep the catheter, then what happens? If we don't keep the catheter, then there is stricture formation at the injury site. So for that, you'll have to do again stricturoplasty and all the management of stricture. So there is chance of stricture formation. So this is one. And number 2, there may be urinary incontinence, because during this injury, there is a chance that external urethral sphincter is destroyed. Okay, and the continence of urine majorly depends upon the bladder neck, because all the external urethral sphincter is destroyed. So here the external urethral sphincter which is there, here this is destroyed. So once this is destroyed, then bladder neck is required for competence. Okay, but this is not so appropriate. Okay, so whenever there is prostatic hyperplasia, when we do prostatectomy, so this bladder neck may not be may become incompetent again. So that is urinary incontinence. And the third one is impotence. This is because erectile dysfunction. This is due to the damage of nerves of penis. So, in some we can treat it by prostaglandin injections. but these work only in some. Or you can give vacuum device or sildenafil. So these work only in some patients. And then fourth one, orthopedic complications. This is because of fracture of pelvis. So whenever there is fracture of pelvis, there are some orthopedic complications. And number 5, extravasation of urine. So for this, the major treatment is to put a drain by suprapubic cystotomy. So these are the major complications of urethral injury. Thank you guys for listening my lecture. If you have any doubts, just comment it in the comment section. Thank you guys.